Hello, my name is Debra Roberts. I'm the chair of the Stoughton Select Board and chair of the Stoughton Equal Opportunity Committee. I'm here with Erin Roberts, Community Representative Coordinator with AdmiTech Foundation. We are here to celebrate Black History Month. Black History Month allows us the opportunity to celebrate the contributions of African American to the American citizens. During Black History Month, we highlight the disparities in society relative to the opportunities available to Blacks as opposed to whites. Some of these disparities are quite obvious, including the obvious disparities in the care for prostate cancer.
Hi, hello. My name is Erin Roberts, and I am one of the community coordinators for AdmiTech Foundation nonprofit organization. I have lived in Stoughton all my life. Went to Stoughton Public Schools, and I am a graduate of UMass. Here at AdmiTech, we do research in regards to prostate cancer. AdmiTech just launched an equity program that allows free pre-screenings for men 40+ years old, especially Black men in our community. AdmiTech is partnered with major health organizations and hospitals such as Tufts, Brigham and Women's, and MGH. Please go to www.admitech.org to find out more information about the new equity program that allows free pre-screenings for 40+-year-old men, especially Black men in our community. Thank you, and I hope to see some of you soon.
Dr. Wason, are you ready?
I am. Thank you so much. And I really appreciate the invite, especially such distinguished panel of guests. And so we all know, 1 in 6, 1 in 8 men will be diagnosed with prostate cancer in their lifetime. And really the goals of prostate cancer screening are to maximize the detection of the intermediate and high grade cancers, to really minimize the detection of non-life-threatening cancers, and then really decrease the unneeded biopsies and treatment of men. And so we're fortunate in that we have the American Urologic Association every year. They come up with these new guidelines. This was the guideline for early detection of prostate cancer in 2018. And really, when we say early detection, it really means screenings. And this implies detection of disease at an early pre-symptomatic stage when men would really have no other reason to seek medical care. And so what does the panel recommend? So it recommends against PSA screening in men under the age of 40. So in this age group, you don't have to worry. There's a low prevalence of clinically detectable prostate cancer. In men that are in between the ages of 55 and 69, you want to proceed with what we call shared decision making. So a decision made between the care provider and the patient. And I think that this particular age group really benefits the most from screening for prostate cancer. And the panel doesn't routinely recommend PSA screening in men over the age of 70. Doesn't mean that you can't get a PSA done if you're healthy and over 70, but we don't typically recommend screening in asymptomatic men. So how do we find prostate cancer? PSA, it's a blood test, digital rectal exam, quick exam, and it's done best in combination. So we combine PSA, digital rectal exam. For the most part, this is done annually, but in order to make the diagnosis, you really need a prostate biopsy. So what exactly is prostate-specific antigen, PSA? It's a protein in semen which liquefies the ejaculate. It circulates in the blood of all men with intact prostates, meaning that if you had your prostate removed, the PSA should be undetectable or zero. The good thing is that it's only made by the prostate. However, it can be elevated in certain conditions such as inflammation, infection, trauma. But it really is like the first early biomarker that we have, and it's used in all phases of treatment. So screening, diagnosis, after treatment, it's used in advanced disease and metastatic disease. So from a urologist perspective, most agree that mass screening is in the past. We do know that PSA has several limitations. We advocate for shared decision making. And then there are high-risk patients that really should be considered for screening. So these are patients that have a strong family history of prostate cancer, and not only prostate cancer, but breast, ovarian, African-American men. Age and comorbidities will often dictate the action, and then who gets screened is dictated by the primary care doctors, and then we're the ones that often dictate who gets biopsied. And so in terms of early detection, if the PSA is less than 1, this is great, especially if they have a normal digital rectal exam. You can expand the intervals between time that you get a PSA. If the PSA is between 1 and 3, you can repeat the testing in about 1 to 2 years. The patients that we want to see in the urologist office are anyone over the age of 50 with a PSA greater than 3, suspicious digital rectal exam. And then these are the patients that we really want to put into 2 categories. Do we have a high suspicion of prostate cancer or low suspicion? And there's several tests that we can do in those with a low suspicion to really rule out the patients that don't really have a risk of prostate cancer. But we can use things like MRI, biomarkers in these group of patients to really figure out who needs a prostate biopsy. So any men that comes in to see me, they can come in with lower urinary tract symptoms, elevated PSA. We'll typically do a transabdominal ultrasound. This is a non-invasive test. We get immediately the size of the prostate, the anatomy, is there any other pathology located into the bladder. That will combine with PSA and a digital rectal exam. If there's concern for prostate cancer, then there's really 2 types of biopsies that we do, transperineal versus transrectal. Historically, the transrectal ultrasound is quick, it's easy to perform, but we've realized that there's increased risk of bacterial contamination. And so your urologist may offer a transperineal route, which can target anterior lesions in the prostate and really virtually eliminates any kind of infectious complications. So I think urologists are moving towards the transperineal approach. And there's a transrectal probe. It's a great way of imaging the prostate and reaching it. There's a different type of ultrasound. This is a high frequency ultrasound. Fortunate to be part of a large urology group practice in Virginia Beach. And we were one of the early centers using this particular high intensity ultrasound to image the prostate. And this one particular group, ExactView, came up with a scoring system. And so under real time, using just ultrasound, you can get a pretty good determination of areas within the prostate that you want to target with biopsy. And so it has a higher frequency than the traditional ultrasound that's being used. We typically take 12 cores, and these are done in the peripheral zone of the prostate. And this will tell us the grade, how aggressive the prostate cancer. Gleason 6 is least aggressive, 10 is more aggressive. What is the volume? Where's the location? And we've come up with this new terminology just to make it easier for patients. Grade group 1, low risk, grade group 5, high risk. And really, this particular scoring system is based on the gland. We're using multiparametric MRI more and more common in the pre and the post biopsy phase. A lot of insurances will not pay for the MRI before a biopsy. If you're lucky enough to get one, I think that this is the way to go. And really it's a great way of determining suspicious areas within the prostate. And you can also evaluate the local extent of disease, such as seminal vesicle invasion, extracapsular extension, or lymphadenopathy. And then we have this PIRAD scoring system, which is called the Prostate Imaging Scoring and Data Systems. And what we're really concerned is the PIRAD's 4 and 5 lesions. And so the radiologist is able to let us know, is there any areas within the prostate that we need to target? If there is, then what we can do is we can fuse using computer-aided software, the MRI to the ultrasound, and we can essentially hit the particular lesion that we're concerned about. So we know that prostate cancer is a wide spectrum of disease. This is a National Comprehensive Cancer Network. We divide patients into very low, intermediate, high, and very high risk disease. Patients that have very low and low risk disease, we tend to steer more towards active surveillance. So we'll not immediately treat you, but we'll watch you very closely. For patients that are intermediate, high, and very high risk disease, these are the patients that we really want to treat up front. We're using biomarkers, and some of these are blood tests. Some of these use tissue from the actual biopsy specimen. There's a variety of molecular biomarkers available for risk stratification. And this is for patients with suspected or known prostate cancer. And they can really be used in all aspects of patient care in the pre-biopsy phase, prior to rebiopsy, and also post-treatment. We don't routinely use these for all patients, but it's best used in combination to risk stratify patients. and their use is supported in a variety of clinical guidelines. This is just one that we typically use here at Boston Medical Center called Oncotype DX. And the tissue that's taken out in patients with low risk disease can be sent to this company to looking for aggressive genes, and they'll give us a score based on the patient's likelihood of prostate cancer death and metastasis and adverse pathology. The traditional imaging that we use after a positive biopsy are CT scan, which is cross-sectional imaging, and bone scan looking for metastatic disease. We still use these, fairly routinely in patients with high PSA, aggressive prostate cancer. But I would say that the new kid on the block is the prostate membrane specific antigen. This is a PET CT scan. So it's really a functional study. And so you use some radio pharmaceutical agents and you bind them to PSMA, and this really looks for prostate cancer outside of the prostate. So if you have a high-risk patient that you're concerned about disease outside of the prostate, this is the go-to test to get. It's also used in patients who've been treated for prostate cancer and now they have a rising PSA and you're concerned that they have disease. And so you get these phenomenal pictures where it really highlights areas within the prostate and outside of the prostate that you want to target for prostate cancer. So in summary, I would say that prostate cancer is common. Its aggressiveness is quite variable among men. Earlier detection, like mentioned several times, is favorable. We really want to maximize detection of intermediate and high-grade cancers and really minimize detection of non-life-threatening cancers. And we're using imaging and genomics to improve risk stratification in our men with prostate cancer. And this has really allowed urologists and patients to be a little bit more comfortable with active surveillance and treat the men that really need to be treated. So I appreciate the time. Thank you.
Thank you everyone for joining today's infomercial. We look forward to your joining ADMITEC's May 4th prostate cancer event to learn more, such as how serious this disease is. Black and brown males are 2.5 times more likely to die of prostate cancer. It is important to get pre-screening, age 40 for black and brown males, age 50 for all other males. Thank you, and I hope this information was helpful. See you next time. Bye-bye.